Good afternoon and welcome to this afternoon's question and answer session with Facebook Live, with Instagram Live. My name's Jane, I'm one of the nurses and I'm here with Louise, who's also one of the nurses at Breast Cancer Now.
Right.
So we're here for the next half an hour to answer your questions, any questions that you might have about breast health, breast cancer, whether it's yourself affected or somebody you know. Do remember it's a public area, so your questions will be seen by anyone else who's joining us. You are very welcome to call our helpline on 0808 800 6000, and you can also send us a direct message on Instagram if you'd prefer. That's absolutely fine. So we're going to kick straight off with a couple of questions that we've had in. So anything I've forgotten, Louise? Anything that I need to mention, or shall we start? I can go straight in, can't I? Lovely.
Get started.
Okie dokie. Right. So, Cal has asked about whether we plan to ask for the screening age to be lowered, so the breast screening program to be lowered.
Okay, so just for those that are watching who may not know, currently in the UK, women are invited for breast screening from the age of 50 every 3 years, and they are for a mammogram. And that goes up to the age of 70 as part of the NHS breast screening programme. After 70, that can continue. You won't be invited, but you can continue to request every 3 years. So I think in response to Cal X's question is certainly there is a trial that is looking at lowering the age, and that trial is called Age. It's closed for recruitment, but it has been going, I think it started in sort of 2009 and it closed at 2020. And that was looking at extending the age to 47, lowering it to 47, up to 73. Now, unfortunately, that's not due to report until 2032. There might be some earlier results being reported at about 2026 to look as to whether that would be effective or not. Now, some of the reasons that people often say, why is it not lower? We do know that younger women have much denser breasts. So mammograms can be quite difficult in a younger woman's breast to be able to detect any changes. So that may be one of the reasons why screening is not currently done at a younger age, but hopefully this trial may give us some of the answers to that. The other thing that the NHS has been looking at is something called risk stratified screening. Again, this is something that's very much sort of, we're looking at the data as to whether the people that are much higher risk, so maybe have a family history, a gene like a BRCA gene, who are at much higher risk of getting breast cancer, already do get increased screening, but whether sort of more routinely people that have risk factors that might elevate their chance of getting breast cancer, they would have more regular screening, and those at a much lower risk may not need so regular screening. So they may not even need 3 yearly screening. We're not there yet with that, but certainly that's something our policy team, any of the evidence they really push for the NHS to implement once that evidence is there to say. I think the other thing to say is that the really important thing is screening is one way of detecting breast cancer, and that's every 3 years. It's really important in between those screenings that we're breast aware, and that's getting to know what your normal is. And if you're not sure and you notice any changes, it's really important that you've got the confidence, because you're regularly checking, to go to your GP with those changes. And if you did have a change, then the GP would make that assessment and refer you not to the screening program, but to a symptomatic breast clinic, and you would have investigations done. If you're at a younger age, usually that wouldn't be with a mammogram in the first instance, it would be with an ultrasound, and then it may be a mammogram afterwards. Is there anything else from that, Jane, that you would add to that?
No, just to mention that the signs and symptoms to be aware of is all on our website, isn't it, Louise?
Yeah, and lots of people are not sure. Sort of, again, everyone sort of knows about a lump, but it's the other ones that they're not so familiar with. And when we talk about breast checking, there's no particular way to check. We've got a TLC, which is touch, look, check, and we've got all the information about that on our website. And that just includes all of the breast, but it goes right up to the collarbone and right into the armpit, and just being mindful. So a lump is one of the things. It might be a thickening or a change to the size or shape of the breast, changes to the nipple, so whether that's inverted, or a crusting or a rash around the nipple, or nipple discharge. So any changes that are new for you and persistent, it's really important to get checked out. And lots of people will ask about pain. Breast pain is common, but on its own is not usually a sign of breast cancer. And there's the other thing to say, although we say about lumps, is the majority of lumps or bumps that you feel won't be breast cancer. There's lots of other things and lots of reasons as to why you can get changes in the breast that aren't breast cancer.
Yeah, that's a really good point, isn't it? Because we're all aware of breast cancer. It's what everyone knows about, but you don't hear about these other breast conditions that are out there and that you can develop and that can have very similar symptoms to breast cancer, but are completely unrelated. So, yeah, and like you say, it's important for everyone to be breast aware, and that information, the touch, look, checks, all on our website. We've also got a booklet which is Know Your Breasts, a guide to breast awareness and breast screening. So yeah, it's really important for everyone to be breast aware, whether they're a screening age or not. So yeah, I think that's covered that, Lou.
Yep, and we haven't got any other questions who've come in live at the moment, but another question that was submitted before from Jen is asking about tamoxifen, and do symptoms really vary with different brands?
Okay, so tamoxifen is a form of hormone or endocrine therapy that's given to women who have an ER or estrogen receptor positive breast cancer. It's one of the hormone therapies that are available. There's another group of drugs called aromatase inhibitors. And what you're prescribed hormone therapy wise depends on whether you're ER positive, but also your age, whether you've been through the menopause. And these drugs, all of these hormone therapies, have a range of side effects. They're given to reduce the risk of the cancer coming back in the future. So they're really important for a lot of women to take, but they need to be taken for 5, sometimes 10 years, and they have a whole range of side effects which can really impact on somebody's quality of life. The majority of those are very similar to menopausal symptoms, so hot flushes, joint aches and pains, vaginal dryness and soreness, low mood, libido can be affected, hair can thin. So, these drugs, like I say, if you're on them for 10 years and your life's being affected in this way by these, it can really have a big impact on you. We do know that different brands, although the drug, the actual drug itself, whatever pharmaceutical company is making it will be the same and having the same effect. But we do hear from women on our helpline and through our Ask Our Nurses service who do find that a different brand does suit them better. So it's worth making some notes, keeping a bit of a diary of symptoms and side effects. If you find you're better on one brand, you can ask your pharmacist if that's the one they can supply. It all does depend on the supply chain. So what can be particularly difficult or frustrating is you may find a brand that suits you, but your pharmacist no longer gets it supplied to them, so you might have to do some ringing around. And even we hear of women travelling sort of some distance to get a brand they want because that's the difference it makes. So if anybody is having difficulty with side effects of hormone therapies, there's lots of information on our website. And you're welcome, like I said at the beginning, to give us a call on the helpline. We can talk all this through and help you with any sort of side effects or difficulties you're having on hormone therapy. Anything else?
No, just
that,
you mentioned the booklet we've got on menopausal symptoms and breast cancer.
Oh no, there's menopause. Yeah.
Talks around sort of ways to manage it, and again our sort of our moving forward program, which I've just done a Q&A session at today actually, is for anyone who's finished hospital-based treatment in the last 2 years, and lots of people who are struggling on hormone treatment will go to those sessions, and it just, we know that when hospital-based treatment ends, it can be sort of, you can sometimes feel that you've lost touch with your treatment team, and it's just another way to connect with others who are at a similar point in their sort of their treatment pathway.
Yeah, absolutely, good point. So we've had a few questions in. So Tracy asks, a friend had a mammogram and an ultrasound. The mammogram that didn't pick up the cancer, I'm thinking, but the ultrasound did. She has cancer in both breasts. Is this normal?
It's not normal, but it's not common to have bilateral breast cancer. It happens, doesn't it, Jane? And sometimes, it can happen for no reason, as to some people will just get what we call bilateral breast cancer, which is breast cancer in both breasts. And some people can get bilateral breast cancer because they have an increased risk due to family history. And I don't know that. We do know that mammogram is the most effective screening tool, but it doesn't pick up all cancers. So it may well be that ultrasound or MRIs are another way of detecting a cancer. Was that the question?
Yeah, the mammogram didn't pick it up, but the ultrasound did. So again, it might be to do with the breast density as well, like you were talking about earlier.
She didn't say how old her friend is either. So it might be that she's of a younger age, or some women just naturally have denser breasts and it's much more difficult. Or the other thing is the type of breast cancer. So a type of breast cancer called lobular breast cancer it can be picked up on mammograms, but for some it's more difficult to pick up. And in the case that if a lobular breast cancer is identified, often you would be offered an MRI just to check the extent of the size of that breast cancer.
Yeah.
And actually, Layla's asked why not go directly to an MRI of the breast if better detection. Jane.
Yeah, it kind of follows on with what you were saying, really, that the mammograms are the most effective screening tool we have, and that's been evidenced from all the research that we have. An MRI is sometimes used after a diagnosis to get a more detailed picture of exactly what's going on, but it's not something that would be used in screening. The mammogram is still found to be the most effective thing that we have. Not 100% foolproof, as you say, Louise. Not everything will be picked up, but MRIs are really only reserved if somebody does have a breast cancer diagnosis, or sometimes in those with a family history, perhaps. Because they've just not, they've not found to be superior to what we have as a screening tool.
They're really quite sensitive, aren't they, Jane? So they can pick up a lot of things that are not necessarily abnormalities, but they will pick up sort of it almost like we'll go, that's something, and then you need further investigation to know what that something is. So you can spend a lot of time chasing things that maybe aren't needed to be chased with an MRI.
Yeah, causing a lot of anxiety as well. Yeah. Claire asks, would hormone treatment be needed for someone with a small area, 3 millimeters intermediate DCIS, so that's ductal carcinoma in situ, after RT radiotherapy?
I think it's a tricky one, because we would always say treatment teams will know best as to the recommendations. For some DCISs, when they're very small, and also when we talk about DCIS, ductal carcinoma in situ, which as Jane has said, there's different gradings. So there's low grade, intermediate grade and high grade. And I think it would be a treatment team and a multidisciplinary team recommendation as to whether in your scenario, and we do know for some, when they're very small, the treatment team will I was going to say, really is larger and the higher grades, isn't it? That they like.
Yeah.
It's not clear cut, but it's a conversation for you to have so that they can talk through your risks and benefits, really.
Yeah, absolutely. Shall I go on to ask the next one, or do you want this one about zoledronic acid?
Yeah. It's, again, I think this is, so zoledronic acid just generally is usually recommended for women. It's not something that sort of, it comes hand in hand with anastrozole. It's more about the type of breast cancer you have and whether you're pre or postmenopausal. So zoledronic acid is given in early breast cancer. And again, I don't know if this question is around that, but for the purposes of we're talking about primary breast cancer, is given to reduce the chances of breast cancer coming back in the bones in the future. It's usually given to postmenopausal women who have breast cancer that may have gone to the lymph nodes or other features of their breast cancer, which may show that it's got a high risk coming back in the future. So it's something I think you would need to have a discussion as to whether or not it would be needed with regards to your individual situation. Would you say that, Jane?
Yeah, so not everybody would need zoledronic acid with an anastrozole. It's not always prescribed at the same time. It's not necessary. So it's not always needed with an anastrozole. It does depend, like you say, on your individual situation and your bone density and your individual risk of recurrence.
I suppose that's the other side of things, is whether the question's being asked on the back of, is it needed for almost sort of like its bone protective properties? I wonder whether that's...
Yes.
Again, often with these lives, as we said at the beginning, sometimes because they're only sort of snippet questions, sometimes you can get a much fuller answer asking, calling the helpline, speaking to one of our nurses about your individual situation, and we can talk it in a bit more detail.
Yeah.
Do
you want to ask another one?
Yeah, so Pocket Rocket has asked, I had triple negative 2013 in the first breast, then 2015 in next breast. I'm 53, obviously haven't had periods since 2013 from treatment. I'm suffering from what I think is menopause symptoms. Help. So
yeah,
that's really difficult. And I presume... So you're 53 now, and it doesn't say, but I would imagine that in 2015, we don't know whether that was a triple negative and whether or not you're on hormone treatment, possibly, or not. So again, it sounds like, I mean, if you are suffering with menopausal type symptoms, and again, it might be worth giving us a call. What do you think, Jane?
Yeah, definitely. And Pocket Rocket, you're not sure what menopausal symptoms you're experiencing, or what symptoms, I mean, if they are sort of related to that or something completely unrelated entirely. It all depends on what the symptoms are. But yeah, if you can give us a call, we'll be able to help you much more.
And as we mentioned, the booklet, but there are lots of resources for people that are struggling with menopause.
Yeah.
And I think it can be particularly difficult when you've had a breast cancer, even if it's triple negative, because there's so much in the media about sort of HRT. And we know that for most people who have had breast cancer diagnosis, they can't have HRT. So it's looking at what the alternatives might be. But certainly do get in contact or have a look on our website and see the resources that we've got.
Yeah, there are lots of things that can help with menopausal symptoms, like you say, that are not HRT. So whether these are prescribed medications that can help reduce things like hot flushes, or whether they're non-sort of pharmacological ways of managing menopausal symptoms, kind of depending on what they are. So there are. It's not that HRT is the answer to menopause symptoms and nothing else is, because there are things that can help. Definitely.
And certainly even lifestyle changes, isn't it? That it's about sort of, and again, it's not easy. It's of trial and error. And I know I've spoken to lots of people that sort of feel that's not sort of something they sort of feel that's going to make a big difference, but actually keeping a food diary, seeing triggers, things like spicy foods, alcohol, caffeine can all make a difference. And again, sort of, exercise can really help with some of the menopausal symptoms. So do have a look. And I think another question we get often asked is about supplements, isn't it, Jane?
Yes,
with
definitely.
Menopausal, can I take certain supplements? And we always say that the regulation is not as good as it is for sort of pharmaceutical companies with the sort of medicines over the counter that you can buy. So you can never guarantee that's regulated in the same way.
No.
A really good resource that we often signpost to, which is Memorial Sloan Kettering Cancer Centre, and they have sort of an A to Z of herbs and supplements. But the bottom line is, we would always say check with pharmacists, treatment teams, GP before taking any supplements, because sometimes there can be interactions if you still are on medication. If you're not, just because of your background of having a breast cancer diagnosis, it's also being mindful of that.
Yeah, definitely. Thank you. Emma Ann has asked, my mum passed away from secondary breast cancer before 50. Does that mean I would be likely to get breast cancer in the future too?
And we get asked this a lot, don't we? I think lots of people, understandably, particularly if you've lost your mum to breast cancer at 50.
Mm.
It's understandable to worry about your own risk. We often say just having one family member with breast cancer doesn't increase your risk, and it's usually more than 2 direct relatives at a younger age. And we know that 50, although that is young, it's sort of anyone 50 and over, we know breast cancer is common in that age sort of bracket. Usually it's sort of around the 40 sort of and below. If somebody got breast cancer at a earlier age in their 30s or 40s, it might sort of give us a bit of a could that be something to do with the family history? And it's not just the female relatives to be aware of, it's also sort of male relatives as well on one side. So it's not just thinking if your dad's side's got it and your mum's side's got it, it's adding up that risk. It's looked at individually. So I would say if it's only your mum, then probably your risk is no more than the population risk. But if you're worried, you can have a look at our information. Again, on our website, we talk through sort of the criteria that we would sort of deem somebody to be at a more increased risk, or go and speak to your GP as well.
Yeah, absolutely. Shall I?
Do you want me to ask the one about
Yeah,
letrozole?
you can do, yeah.
Joanne's asking, I'm taking letrozole. Is there anything I can take for aching bones?
So letrozole is one of the aromatase inhibitors that we mentioned earlier, a form of hormone therapy that's given to reduce breast cancer returning or to treat secondary breast cancer. And one of the main side effects is that it can cause real joint aches and pains. And often we hear people call this letrozole legs, or people describe feeling sort of in their 90s when they're only in their 50s. It can have that real sort of aging effect on just how you feel. There are some things that can help. We know that being a healthy weight, a healthy BMI does help. Some people find that regular exercise does actually help improve the kind of aching of the legs, and that exercise would vary. It doesn't have to be anything particularly strenuous or anything that puts a lot of pressure on your body at all. It's just walking, swimming, anything that's kind of getting your body and your joints and legs and arms moving. Pain relief, some people find that they might find it helps if they take some pain relief when they first wake up in the morning, if that's their worst time. Sometimes swapping the time of day that you take these tablets can make a difference as to when you might experience the side effect. So sometimes people find that helps. Again, on our website, we've got a lot of information about these drugs and these side effects, including joint pains and aches. We've got sort of 5 tips to help them with joint pains on our website, because that does it can be a real big problem, and some people consider stopping their hormone therapy because of a side effect. What can be helpful is sometimes it can be difficult to know with a symptom. Is it a drug? Is it just general aging? Is it something else that's going on? Sometimes treatment teams may suggest to somebody that they temporarily stop their hormone therapy for sort of 6-8 weeks maybe, just to see if there is a difference to that symptom, and if obviously there's a vast improvement, then you know that it was that's causing it. And then options are, do you go back on it, find ways to manage that side effect? Do you try different type of hormone therapy? Because although they're quite similar, it's a bit like the brand thing. You can find one drug suits you better than another. So I mean, the key thing is for anybody is not to suffer in silence. Don't think it's something you've got to put up with or be grateful for because you're having your breast cancer treated, or you're on treatment for it. Do reach out to your treatment teams and let them know if you're having side effects from any of these therapies. I would suggest. Anything else you think about, Louise, about that? No.
I think you've covered covered sort of, I suppose the thing is given permission. I think so many people worry about bothering their treatment teams, don't they? When they're finished, they sort of feel that the focus is on those going through treatment, and don't ever feel that you're sort of wasting anyone's time or you're bothering anyone, because that's exactly what they're there for.
Yeah.
And even if it is calling us first to get that permission and talking it through, and that we signpost, is sometimes that's easier once you've had a chat with one of our nurses, because we do have the luxury of time that I know our colleagues in the NHS don't always have, but they will always be there to hopefully answer and refer you on if need be for extra support.
Yeah. Okay, let's try and get another couple in, shall we, before we finish? So Srijas asks, hi, please, can I know what sort of things I can drink during chemo?
So there isn't really any restrictions. It's just about being hydrated, I think, is what you're asking. So you can continue to drink teas, coffees, if that's what you drink, juices. I mean, the only thing we would probably say is, again, and it's just around sort of the sugar, is avoid too many sugary drinks. But it's more about keeping yourself hydrated. And there's not a sort of a magic number that you've got to drink X amount. It's just about sort of, doing that. I don't think it's a particular...
No, it's often, we used to sort of say at least 2 litres a day, but that was very much kind of a guide, which, water, squashes, there's no specific drinks that you have to have, or obviously we're not talking about alcoholic drinks, but it's, being well hydrated, like you say, Louise.
Yeah, and I suppose some chemotherapies can alter your taste slightly. So you might find that some drinks you would normally drink can taste a bit bitter, a bit metallic-y. So again, it's just finding something that is acceptable to you, that you can take, really. KB's asked, can I start exercising 6 weeks post-op from lumpectomy whilst waiting for treatment plan and chemo to start? Diagnosed triple-negative breast cancer.
Yeah, so providing, KB, your wound is completely healed, there's no sort of gap or opening or infection, and you're feeling well, then that's absolutely fine. You can certainly start exercising. You might want to consider what exercising you're doing. You might not want to start on a brand new exercise. Although if you did, that would be okay as well. It would depend on what it is, and to build up slowly. Again, we know walking, is really good for our sort of physical and mental health, and any form of physical activity, really. So lots of people do like to sort of think about things like yoga and Pilates at this time, because it can be a more sort of, it can feel a gentler form of exercise. It's also good for sort of mind and soul. There's no reason why you can't exercise 6 weeks post-op. It's just, make sure your wound's healed. What is it that you're thinking of doing, and building up slowly. Yeah.
I've just I think we missed one right at the beginning. Yeah, I was just going to touch on it, really. And Holmes has asked, and certainly I just a bit of a signpost, really. She said, I've been prescribed elacestrant yesterday. I've lived with metastatic breast cancer for 7 years now. First person in my area, Hull, to start on these meds, and wondered if you have any advice, please. And that's really difficult, I think, when we get these new drugs through, and we often get people on our helpline, don't we, who'll sort of say, I don't know of anyone else who's on it. I don't know sort of the side effects. And obviously we've got some information on our website, but it might be that you might not have anyone in the area, that's your hospital, that started on it, to sort of touch base, check in with. But our Living with Secondaries breast cancer meetups is a way that you might be able to connect with others who are on it, or our forums. If you post on the forum that you're starting on it, or and has anyone got any advice, you might be able to connect again with others who have been on it or have recently started on it, and that's just another way that you can gain support, really.
Yeah. And Colorado Mama's asking about the CHEK2 gene. We've got information on our website. I'm aware that we haven't got a lot of time to go into that, but we've got information on our website, as well as an information booklet about family history and breast cancer, and it does talk about CHEK2 gene, as well as the more common ones, BRCA1 and BRCA2. It's
a really good website as well. It's an American website, but really informative, called Force, which goes into a lot of detail about the different genes as well. So that talks about the CHEK2.
Yeah, brilliant. Okay, I think that's covered all of the questions. Thanks ever so much for joining us this afternoon. Our next live is on Tuesday evening with our colleague Vic. She's talking about mothers and daughters with breast cancers, and she's got guests joining her for that. That's at 7 o'clock on Tuesday. That's correct, isn't it, Louise? I've got that right. So by all means, do join us for that as well. And like we've said, do give us a call, 0808 800 6000, if there's anything else we can help you with.
Great. Have a good rest of your days.